thank you very much for the invitation to speak. It's an honour. Interestingly, as you saw me faffing around with my computer here, the original presentation that I've got for this is not the presentation I'm going to give you. I was on call last night doing obstetrics, which is pretty germane considering what I'm talking about today. And during the middle of the night, as always, I get this sudden brain, and I have to change my presentation. Well, of course, I made the big mistake of using one of the hospital computers, and that is the death knell for any PowerPoint. Anyway, having said that, I always have, one has to be able to adapt in our business, and so I've adapted and I've decided to use another presentation, which is called Bums, Bladders and Birth, which basically is the same thing. I do obstetrics, I do quite a lot of obstetrics, and it's very interesting talking about birth injury and birth trauma. I was working last night, and I put a pair of forceps on about 2 o'clock this morning, and to more intents and purposes, everybody says, well, it's forceps, what's the big deal? And, I've been doing obstetrics for 30 years, and this is the reason why I went to change the presentation, by the way, because I put a pair of forceps on, and I got this bright spark idea about forceps and the issue with forceps and delivery and pelvic injury with birth. So there are a set of slides here. As usual, I tend to get off point on the slides, but still. The thing about injury and birth, it's really a very big topic at this point in time. And it's become a big topic in the media specifically because the talk about how one can protect the pelvic floor from birth and birth injury, specifically pertaining to patient-requested caesarean section, which is now a huge issue to the point that we see it in all national newspapers, to the point that one of my colleagues wrote a book about choosing caesarean section, and he believes everybody should have a caesarean section. Now, that would put him somewhat out of business, but he still has written a book regarding choosing caesarean. I don't follow that, and I think there's some aspects of this which are very interesting in the pelvic floor from birth point of view, and I think we can actually improve the quality of patients' lives post-birth and perhaps be able to have algorithms by which we can avoid the pelvic trauma better than we have in the past, where it's been, well, someone's going to have a vaginal birth, what comes afterwards is that happens after birth. Well, I really don't think we're allowed to say that anymore, and I don't think we should be allowed to say that. The objectives I want to talk about today, I talk about birth injury and its etiology, underlying causes, strategies to avoid actual injury, and interestingly, there are some strategies now which the Cochrane Review, and I'll go into the Cochrane Review, has talked about regarding prevention, management strategies, and what to tell patients. See, you say, well, we're nurse continence advisors, we really don't see these patients, but actually by default you see them all the time and don't really recognize that some of these things have happened from birth. So it's very easy for me to stand up here today and say, okay, I'm going to talk about incontinence and prolapse. Well, you know that. The things I'm going to talk about are the things that I find that are common in our practice, in obstetrical practice, but are not really front and center, but you see them in your practice and wonder what to do with them, because invariably you'll see them many, many years down the road from birth and wonder, can this be due to childbirth or can this be due to something different? What I will focus on most is an interest of mine, which is basically anal injury and pelvic floor injury from an anal injury point of view during childbirth, and talk also about voiding dysfunction, because that's something you see in your practice as nurse continence advisors, but don't recognize it, perhaps you do, recognize that it backdates to pregnancy and delivery. So these are what issues that challenge the obstetrical provider. What happens is when patients have a baby, everything's taken up with the baby, and the kind of mother takes the back, as it were. And when they go to a 6-week visit with their practitioner, what happens is the practitioner will say, pat the baby and everything else, ask how the breastfeeding is. Maybe they'll touch on urinary incontinence. And over the last 20 years, as you well know, urinary incontinence is something people have spoken about now, which they never spoke about 20 years ago. Now, what patients are speaking more about now is actual anal incontinence. Now, of course, it's not as frequent as urinary incontinence, but it actually is very frequent that people get, and the incidence is quite high. But again, it's one of these, just like urinary incontinence, it's one of these things which is basically a hidden problem, if you will. But it shouldn't be hidden because there are ways we can address this. I always like quotes. I love quotes, and this is one of the quotes from quite a famous person who delivered babies back in the 19th century. And really, from a point of view of birth injury, it doesn't matter. I may focus a little bit on anorectal injury in this talk, but really it goes for all the injuries we get and all pelvic floor trauma. You see, pelvic floor trauma, it's divided basically into three main categories. The first category is the obvious one. It's the mechanical trauma. It's the obvious thing. If someone has a baby and there's a big tear, will have had trauma to the pelvic floor, and certainly, and most likely to the pelvic floor. Then the other two are sort of relatively hidden. The neurological injuries you get associated with childbirth are frequent, and they actually contribute to the dysfunction that patients have after birth. So, people come in and say, well, you know what, I had this big tear, but I still have issues afterwards, even though the tear was repaired and I've done physiotherapy and everything else. Well, oftentimes these patients have a neurological injury, and what happens invariably is that the pudendal nerve, which obviously innervates the pudenda, comes around something called the ischial spine. And I don't know when you examine patients whether you feel where the ischial spine is, but it hooks around there and it gets either stretched, compressed, and so it can have everything from a neuropathy, which can be long-standing, to a neuropraxia, which is relatively, well, hopefully short-standing, but it contributes to it. And the third type of pelvic trauma is a stretch injury. These are studies, and they've come quite eloquent studies actually, and show that the muscles of the levator floor will stretch something up to 3 to 4-fold during vaginal birth, which is pretty amazing because most of the time they will recover and go back to what essentially is normality afterwards. But like any muscle, there is a point beyond which it will stretch no more. So the obstetrical, if you think about it, they were thinking about this back in the middle of the 19th century. And this is a very famous American obstetrician. And in a way, he's sort of right. Interestingly, this is a chap that talked about most lacerations can be avoided, yet this is the chap that advocated that all patients should have forceps delivery to expedite the delivery of the baby. So in a way, I understand his philosophy from a point of view of what he said here, but I don't understand his philosophy from a point of view of the use of forceps. And I'll talk about forceps very shortly because I think that's partly the missing link in this conversation. In our health region, this is relatively old data. This is when I came back. I looked at this when I first came back. And I'm going to come into what the third-degree tear means and fourth-degree tear means shortly. I mean, third-degree tear, we'll come to the actual definition and what it looks like, basically is a sphincter injury. And the problem with it is that probably up to 30% of sphincter injuries are actually missed. They're not recognized, and that's for an old number of different reasons. One reason may be because patients just don't recognize it, practitioners just don't recognize it. It may be because, a patient's had this tear and there's blood and everything in there afterwards, and, they just don't recognize, and the sutures are placed in there in the hopes that it catches it. And some of them tears actually can occur without actually noting a physical tear, going back to the point I've just made about perineal trauma, part of it being stretch injury. And they've shown quite eloquently in studies that anal incontinence can occur even when they've not noticed or there's been no obvious tear of the actual anal sphincter. When I came back here, well, because I was elsewhere in the past, there was no standardization of repair. So it's back to my thoughts again. there was no standardization of the repair, so it was just willy-nilly. What anybody thought was the way to put a sphincter back together, it just got put back together. And there was no standardized postpartum management, because these patients, they need a lot. And I'm going to talk to what they need postpartum as well as intrapartum. Again, it's a motherhood and apple pie statement, but it's true. Anal incontinence is something it's not life-threatening for the most part. It really isn't. However, it's life-interfering from a point of view of the fact that patients, women, sometimes don't want to leave the house because of the slight expectation that they may have an accident when they're out. They don't go to work, so they become socially disadvantaged and sometimes actually quite socially isolated with this. So it's a real problem. And unlike urinary incontinence, where there may be groups of people get together and have maybe a sort of laugh behind the hands regarding urinary incontinence, there's no laughing about fecal incontinence at all. Fecal incontinence takes two real subdivisions, really. One is the urgency, and just like urge incontinence, it's that overwhelming desire to go to the bathroom and loss of bowel motion before they get to the bathroom. It can be solid, liquid, or flatal. And then there's a passive loss, the loss which occurs as a result of the sphincter usually not working that well and not able to hold on to, and it's usually liquid stool. And so if you're seeing patients, and again, it's a conversation it's difficult to have because the patients themselves don't really want to volunteer this information to you. And so you actually have to go asking them about it. Because if you don't ask them about it, they'll never tell you up front. I mean, I will get one person per clinic referred with fecal incontinence, but when I ask them, 10 people per clinic actually have some form of fecal incontinence, up to including flatal. Because often you see this in combination with prolapse because there's been some injury. One fact about it is, and the reason it's caught the attention, for better or for worse, is that it's increasing its lawsuits from a point of view of medical practitioners. And it's due to a couple of different reasons, really. One, I think, is because of poor recognition. And then the second is the fact that it's poorly managed once it's recognised. So it's a double whammy, basically. And then patients end up with surgeries, and sometimes very invasive surgeries way down the line. What happens with it? There's a kind of a double hump of incontinence in its prevalence. The first is soon after birth. So the ones with a direct trauma, direct injury, and it's straight after birth, and we know it. The patient, they've had a tear, there are questions about incontinence, usually by me or physio or whoever. Then there's a group who have never asked. And they're very fortunate because in many ways the levator floor, and we'll come on to the anatomy shortly, which sits above the external musculature of the perineal body, sort of acts as a sort of separate sphincter. And so when people say, tighten your muscles and tighten muscles, what's happened is the levators have by default become the sphincter or become the reinforcement of that sphincter. And so as patients get older, of course, our muscles degenerate. We all know that. Well, the levators are no different. And as a result of that, we see then a second wave, as it were, in ladies in their 40s and 50s. And oftentimes you can backdate that back to the delivery they had 30 years previously. But again, it was unrecognized, or most oftentimes something that was never discussed. And so the patient will say, well, yeah, I was incontinent for 18 months, 2 years after I had the baby, but no one asked me, so I didn't tell anybody. So what is a third-degree tear then? And you just bandy around. And you will see that. I'm going to show you some pictures shortly about what you will see if someone's had a previous third-degree tear. So when you're examining the patient, you will be able to look for these signs, and that may direct you towards potential management and certainly potential questions you ask them. The degrees of tears go 1 through 4. I'm not going to talk about 1 and 2. They're tears, and I don't dispute that, but they don't have the same implication that a 3rd and 4th degree tear has. And I'm just going to skip forward to one slide, and then I can, and I'll talk about this. And I have the pointer's working here? No. Okay. The perineal body is made up of the green muscle, which is called bulbar cavernosus, the transverse superficial perineal muscle, which is the one that comes across, and there's a midline raphe called the perineal body, which is the yellow you see there. Beneath that in grey, the circular sort of target area is the anal sphincter. Basically, that raphe, that perineal body, is a kind of a protector of the anal sphincter. And oftentimes people will consult as obstetric and say, well, I've got an anal sphincter tear. When actually what they've got is a tear of the perineal body, and the muscles of the transverse perineal muscles have actually retracted, so it looks like you've got a third-degree tear when actually you don't. And as you can see, the muscles tend to come in at 3 and 9 o'clock there, as opposed to with the anal sphincter where the muscles fall away. So a third-degree tear, and the ones that are significant, I think the ones that really cause the biggest problem are the ones down 3C and 4. And some people say there's semantics. People have done research to try and suggest there's anal incontinence associated with one worse than the other. They've never really substantiated that well. But intuitively, you'd think, if you have a 3C or a 4, and the 3C basically is the sphincter itself is torn, and the internal anal sphincter. And the internal anal sphincter is basically a continuation of the smooth muscle around the bowel. And what the internal anal sphincter does, it kind of holds the bowel in tone. And what it does by holding it in tone, it allows the bowel motion not to sit right on top of the anal sphincter, but actually hold it well above. And what happens with the patients when they have fecal urgency, there's lots of different mechanisms. One mechanism which is quite good to visualize is that instead of the bowel motion being held up a few centimeters up the anorectal canal, it's actually sitting there right on top of the anal sphincter. And then you think, well, if this person has some injury or some problem with the anal sphincter, it really hasn't got a chance. And that's where the urgency is profound, and that's where patients unfortunately lose bowel motion. A fourth-degree tear is when the actual tear goes up inside the anal canal. And that's a problem on all different kind of levels. I mean, not least of which is a significant tear and actually quite difficult to put back together at times, because you have to put back together the bowel, then the sphincter, internal anal sphincter over the bowel, then you have to reinforce that to prevent fistula formation, and then you have to put back the anal sphincter as well. So, I mean, to do it properly, it takes you an hour or more. I mean, it's not just a few sutures are placed in there. The fourth-degree tears are the ones which have the biggest problems subsequently. They have the biggest rate of breakdown because, of course, they're going to get infected. They're going to get much more anal and rectal contamination. This is a picture I just slammed it off the internet. If you look at the bottom right-hand corner is the fourth-degree tear. And as you can see, and I think you can see the writing there, is the vaginal mucosa is laid open, the sphincter is retracted at the back, and the sphincter comes back almost like as a horseshoe, because it's a muscle, and when it's torn and the muscle's torn, it retracts. And when it retracts, it has that horseshoe type appearance. And so it's basically open all the way up to the rectum. And, you know, it's a terrible thing when it happens, and I must admit, when I see it and people ask me to, my heart sinks, not because of actually fixing it at the time, but what the implication that's going to be. So how frequent is it? Well, it depends who you read. You know, people who think they are really good at obstetrics will quote a 0.5%, and that's because I believe they just don't recognise it, to be perfectly frank. And then 5% is probably realistic. And it depends a number upon delivery factors. The United States has a higher rate of anal sphincter injury, and that's because of some of their obstetrical practices, which are different to what we do here. 20% of these patients have bowel incontinence to some degree. That includes flatal incontinence. The issue is going to be, and I'm going to address this, is how long does that last for? And part of the answer to that is, one, the degree of tear, but the second one is how that is managed after they've had a tear. You know, whether they're seen in clinic, whether they see physiotherapy. So this is just a relative risk, and this is taken from some of the literature from basically 2000 and beyond. But I can't really quibble with this. And really, the big discussion, I think, now regarding delivery is not regarding cesarean section. That sounds better because people talk about patient choice. Where the discussion should lie is the use of forceps or not. And forceps have saved many babies. I mean, they brought babies out who are in significant stress, so I'm not doubting that. However, the relative risk here is sixfold with forceps, and that's on the low end. Most relative risk in most contemporaneous studies now is tenfold. So the argument, or should I say, the discussion now should be regarding forceps and not regarding cesarean section. If you counsel a lot of patients, and especially medical and nursing professionals, when they come and see me and they're requesting cesarean section without labour, and they're saying they want to protect the pelvic floor, by default, actually what they're saying is, I don't want forceps. Because they know that literature is fairly strong that with a spontaneous vaginal delivery without tear and without forceps, and as you can see for this, forceps increases the relative risk significantly of tearing, the risk of incontinence, be it urinary or bowel, is not significantly greater than if they have cesarean section cold. Which indicates to me two things. One is that it's not just delivery that causes this problem, apart from the absolute mechanical tear I've spoken about, the third-degree tear. But it's also the avoidance of forceps. And this is where the big discussion is going to be. I think people have got it wrong discussing cesarean section versus vaginal delivery. What the discussion should be, forceps delivery versus vaginal delivery versus cesarean section. The other relative risks that increase, first baby, well, first babies, women are more likely to have forceps. Epidural, yes, because they're more likely to have forceps. Prolonged second stage of labour, they're more likely to have forceps. So, you know, it's a never-ending, it's a gift that keeps on giving, as it were. And so the real discussion really is what we're going to do about forceps, and are we going to continue to use them? And just to put into perspective, and I say last night, 2 o'clock, well not last, 2 o'clock this morning, I had a pair of forceps on this baby's head. And I'm sitting there and I'm thinking, I'm giving a talk tomorrow this morning about forceps and perineal trauma. And I'm putting them on and I'm thinking, well, should I take them off at this point in time? And I mean, I have a dilemma. I've been doing obstetrics for 30 plus years, and I've probably done more forceps than I care to deliver, and wish I probably not had done as many forceps as I've done. And I'm having doubts about it, significant doubts about it at this point in time. Anyway, you don't want to know about my anxieties anyway. Anyway, so what's the importance of this? What's the importance of a tear? I mean, people say, well, so what, you have a tear and it's fixed, but no, it's not. There's a high prevalence of issues with those tears. 30% flatal incontinence, 8% liquid stool, 4% solid stool, fecal urgency. Fecal urgency is a big problem. It's actually more of a problem. And I think that plays into two things. One is the direct injury, and I think the second is a neurological injury as well. And we do studies called pudendal nerve latencies, which you may never heard of, but basically it's an electrode. I don't do it anymore, but it's an electrode where the electrode goes around the ischial spine, which is where the pudendal nerve curves around, and comes to the pudenda, so out to the pudenda. So you have an electrode, and what you're able to do is you're able to see the speed of that electrical pulse, because there's a pulse on the actual end of the finger. And what you show is that there's a delay in that neurological action associated with the incontinence as well. The question really is, to my mind, is how long does it go on for? Now, we were lucky. We have physios in our clinic who, I was going to give you accolades here, who are very active with this. And so these patients are seen quickly and get onto some kind of care. And it's not just the physiotherapy they get, it's the care and acceptance of why they're having it. It's accepted this is a problem, as opposed to waiting for a year to find out they've still got a problem a year. So you'll say, well, an ounce of prevention is worth £1 a cure. That's what my mother said anyway. And the question is how can we prevent it? Well, don't do forceps, obviously. You've had that conversation already. Birth positioning. Now, if you talk to midwifery groups, they talk about all these different birth positions: standing, sitting, side, lying, ball, hanging from the chandelier. Doesn't matter how you do it, none of them make a difference. The Cochrane review has shown that. Perineal massage, interestingly, does make a difference, and it has statistically significant improvement, as does the warm compresses during the second stage. Now, before I read this, the Cochrane review, it came out in 2015, so it's kind of relatively hot off the press. And it talked about these two strategies as the ways of preventing a third-degree tear. I honestly thought, if you rub tissue for long enough, doesn't it get swollen, and therefore it's more likely to tear? You know, if I put something warm on the perineum and it's ladies pushing for 2 or 3 hours, it's not going to swell and get more likely to tear. Intuitively, I thought that was the case, but unfortunately, I was wrong. As a matter of fact, those two things actually do improve from a point of view of tearing and decrease that risk of tearing. People say episiotomies, and you know, most of your patients, when you see patients, you know, you'll see they've got the episiotomy scar there. I mean, lots of your patients, especially ladies in the 50s, where if you're looking at 30 years ago, episiotomy was the norm. It wasn't maybe we'll do an episiotomy, it was the norm. You got an episiotomy. And the episiotomy was done for 2 reasons. One, because it's thought to make it easier for the mother and delivery, and second, they thought it would actually decrease the risk of tearing. Well, wrong. Actually increases the risk of tearing, as it turns out. And the tear you get with an episiotomy is actually worse than if the patient or the lady is torn directly down the midline with delivery. So episiotomy is, I think I do 1 a year maybe, usually for a breech delivery. And then you can question whether I should be doing that anyway. Not the breech delivery, the episiotomy. These are the positions I've talked about. Again, historical information regarding episiotomy. I mean, so what does it look like? I mean, again, a picture paints 1,000 words. Now, this is what it looks like in real life. And this, I will accept this is a secondary repair. So this is a repair I did for a sphincter injury that had been done, that had occurred many years before. The patient had ongoing issues with fecal incontinence. We do investigations, and the investigations you can do for this are either manometry or you do ultrasound. And ultrasound actually is very sensitive. It's sensitive for internal anal sphincter, and I think I've got pictures to show you. Internal anal sphincter, and it's also very sensitive from a point of view of the external anal sphincter too. Really, the data, and just sort of jumping ahead slightly here, as I tend to do that, is when a patient's considering a next pregnancy, that data is important. You know, again, it's a way you've got more information that you can give to a patient to make an informed decision. So this is a sphincter, and you see the sphincter's laid open. So these clamps on the side, oh, we don't have one. The clamps on the side are basically on the anal sphincter. And there's 2 ways of putting the sphincter back together again. The way we do it when the patient's had an acute injury is to put one end of the muscle to the other end of the muscle and use sutures that don't take away the blood supply. If you're doing it secondarily many years later, what I tend to do is overlap them. So I have one part of the sphincter here and put the other part of the sphincter over the top as well. Because oftentimes there's scar tissue in between. And you can't oftentimes show that, as you can see here, tell the difference between what's scar tissue and what's muscle. So if you don't recognize it, what's the implication of not recognizing a third-degree tear? We've talked about anal incontinence. We've talked about already. This is one lady that is a patient of mine who ended up with a fistula. And fistulation, you may see. And sometimes you'll see these in your practice. And a lady will say, look, you know, I pass a bit of gas through the vagina, or I may have occasional leakage, especially if it's summertime and I've got diarrhea, I'll get a bit of leakage in the vagina. They've had it for 30 years, and so they've got a mature fistula, and they've actually put up with it for that length of time. So I'm going to be disinclined to operate on those patients for a whole number of different reasons, not least of which you could make it worse potentially with these fistulas. Because what happens with these fistulas are the fistulas of the obstetrical fistula are just inside the vagina, where it's very narrow, the gap between the vaginal wall and the rectal wall are opposed to each other. And so those sphincters are very, very short. And trying to get enough tissue to pull across to cover those can be a challenge. And you can, in those situations, I never have made it worse. So what would you see in your practice? And this is what you'd see in your practice. Oops, not that. That. This is called a dovetail sign. And this is the sort of thing you'll see in your practice when you examine a patient. When they've had a significant tear which is never repaired, or it was repaired badly, or if, through no fault of anybody it fell apart, you'll have this. And what I'm trying to demonstrate here is if you look at 12 o'clock, the anal sphincter you see, so one finger at the top there is in the vagina, the other one spread in the labia. What you're seeing at the top there is some of the anal mucosa that's pouching out. At the back, on the skin folds, you've got something called a dovetail sign. And if you look at it, and you've all seen a dovetail where it fans out at the back, this is exactly what this is. You see how it fans back? What that is as the sphincter is retracted, the external anal sphincter specifically, because it has fibres that come to the skin edge and cause it, because normally when you look at it, the sphincter is like the sun, as it were, on the skin. It's got skin folds going all around. When it pulls back into a horseshoe, it pulls the skin back in the same way. So you get this sort of, it's called a dovetail sign. And if you've got that, if you ask the patient whether they have anal incontinence, pound to penny, they'll say yes. Because this is mature. This lady is in her 50s. When she came, she actually came for something completely unrelated to this. So that's the sort of thing you're going to see in your practice. Recognition is always the most important thing. And recognition from an obstetrical point of view is always the most important thing. We're going to talk about, you don't really need to know about how we repair it. I'd say this is not the lovely presentation I actually got ready for you. However, postpartum management is really important. What we instituted in Calgary, which is not fallen by the wayside, but it's been rationalised, it was something called a perineal clinic. And the perineal clinic, with a rave in the late 90s and early 2000s, everybody had to have a perineal clinic. But in a way, I think it was important because it then made people aware of the problem of anal incontinence and tears. The problem with it was, I believe, is it almost directed patients towards having surgery, because if they were that severe, they sort of got on that track because they were seeing me, for instance, and what do? I do surgery. So they're on that track that, oh, I'm going to end up with surgery. That's a bad idea. And really, unless the patient has something like a cloaca. Now, a cloaca is basically like that lady just showed you, where the vaginal opening and the rectal opening are almost one. If you see a patient who's 28 and it's got that and it's got significant incontinence, physiotherapy is going to be first line, but they're going to end up with surgery. They are. That subset are going to end up with surgery. However, the issue with it is that surgery wears off with time. So I can look really like quite a nice guy when they're 28, but when they're 40, they may well be back again, because over time, and this research bears this out, 10 years or more, that actually surgery starts to fail. Do we know the reason why? Not really, and I think it's just the muscular effect more than anything else. I think what's happened when we put them, my feeling is when we've put the sphincter together, we've put muscle on top of muscle. And I think over time that muscle scars and it starts to separate. That's the only way I can see this. Because after we've done surgery, we're always in there trying to get all kinds of postpartum management, good bowel habit, the whole 9 yards. Now what we've done is it's kind of changed in a way where it's basically physiotherapy driven and not driven by me, for instance. And I think that's the way it should be, because physiotherapy has got much more to offer than surgery has to offer in this circumstance. So, postpartum management, this is postpartum management. And the last comment is the most important, is don't tell me it's normal. I mean, just don't tell a patient that having a sphincter tear with some incontinence is normal. The question always is, and the patient will oftentimes ask, is how long is it going to last? And that how long is it going to last really has influence on a number of different things. When you're counselling a patient for a subsequent delivery, and let's jump to, this is a Toronto hospital, circa 2012. When you're talking to patients subsequently about what they're going to do about delivery, the gut instinct would be to say, look, why don't we just do a cesarean section and things will be fine? That's kind of wrong in two places and right in one. One is it's correct, you're not going to have another tear. I can guarantee you're not going to have another tear of the perineum if you have a cesarean section. Two, it does not guarantee you that that incontinence will not get worse during that subsequent pregnancy because of the effect of pregnancy. So you're trading there for another operation with its solving complications. What they say is, and most of the studies, and this comes out of the Cochrane database too, the number of cesarean sections you have to do to prevent one episode of anal incontinence is 11, and that's your best one. That's the one which is the lowest. Most of these studies are in the 20s and 30s to do cesarean section. And you can use your own values regarding what you think is acceptable where that's concerned. And everybody has a different value regarding that. I can't say that's right or wrong. I'm just saying this is the way the figures are. How do I counsel patients? Well, I do counsel patients this. Literature suggested that if a patient has persistent anal incontinence beyond 6 months after they've had a delivery, their chance of having significant anal incontinence with a subsequent delivery, with or without a tear, is present. If you look at the figures, and we've said before, the best people say 0.5% of the first delivery, 5% is the worst or thereabouts, and I err towards the 3 to 5%. The chance of having a tear again, were you to deliver again, all comers, is about 10% of those patients. So you basically doubled the risk of re-tearing through that previous tear site. Of those, 1/3 will have persistent incontinence. I'm not throwing a lot of figures at you, but still, 1/3 will have persistent incontinence. So 3% of those patients who had one tear initially who decided to deliver again will have incontinence which is worsened and persistent and does not go away. Again, degrees of incontinence, platal through to absolute incontinence. But still, it's something you've got to think about where this is concerned. When I talk to patients like this. I say, look, you've had a tear, it's a significant tear, and these are ones that have gone through the sphincter in completion. If you have persistence of anal incontinence beyond 6 months, then I would definitely head towards cesarean section. Because there's persistence, because these patients have had physio, they've worked hard at this. And so, they've made an effort because they've been in our clinic and under our auspices. Two, if we do an anal ultrasound, and actually I'll go to a different presentation and drag it up to show you a picture of an anal ultrasound in a second. If you've had an anal ultrasound, the literature, the Cochrane database, and literature suggests anything greater than 30 degrees of a circle. I'll be honest with you, I used to be one quadrant, i.e. 90 degrees. And if you have that kind of defect, then I think you should have cesarean section. The other thing that's been coming into play now is decreasing squeeze pressures on manometry, which we do, the colorectal surgeons tend to do it more than we do. But what we're doing with that, we're trying to refine it so that it's not everybody gets cesarean section, recognizing that there is a persistence of anal incontinence in patients even if they have cesarean section. I mean, if patients have a primary cesarean section, this is the all-hallow 39-week cesarean section, this is going to protect your pelvic floor absolutely. Well, it's nonsense. I mean, it protects you from a tear, but it does not protect you from anal incontinence because there's an effect on the pelvic floor of the pregnancy as well as the delivery as well. And this is where the balance is going to be. This is where the balance with this cesarean section debate is that, proponents of it say, I'm all for choice. And, human rights lawyers say it's all for choice. True, and I don't dispute what they're saying, but I think it's informed choice as well. And that's where I'm afraid there is a difference. And I'll wear my obstetrical hat here just to highlight an example. With caesarean section, after one caesarean section, there's an increase in risk in something called abnormal placentation. Abnormal placentation means the placenta inserting onto the back of the caesarean section scar. You say, well, big deal, so what? It's on the back of the scar. Well, the caesarean section scar is avascular. So this thing is attached, and I can assure you it's stuck like someone's sutured it there and glue. And I remember, we all remember our worst cases. I remember a lady who had one caesarean section. She'd had a booked caesarean section to protect her pelvic floor. She was a medical professional, as was her husband. She presented her next pregnancy at 25 weeks, so just past viability, with a massive hemoperitoneum from a placenta which had eroded itself through the scar into the abdominal cavity. 35 units of blood later, I wrestled her uterus out, and she spent 3 days in ICU and 2 further operations before she actually escaped ICU. Now that's really quite a dramatic example. But if you turn this card over, on the other side of the argument, people who are very pro-choice will say, proponents of caesarean section will say, look at this dramatic tear. I agree, and I'm not disagreeing with that, but I think it has to be informed. There has been 2 deaths in Canada this year from abnormal placentation, from people who've had on their second caesarean section. So, it's, death, birth injury, you've got to find your own choice where that's concerned. And I haven't really reconciled where I stand on that at this point in time, because I do urogynecology, and because lots of patients come and see me specifically to talk about pelvic floor and pregnancy. Where I'm reconciling it is back to my original discussion point. We have to look at forceps. So taking a slightly different tone, and really what I wanted to talk about today is regarding the things that just you'll see in your practice, but aren't the things that I spoke about. So prolapse, incontinence, everybody's always speaking about this. So, I can stand up here and show you the studies, and you'll say, well, great, I've heard that talk 10 times before. I'm talking about bladder postpartum issues. Now, the physios see them, and I see them, but actually as nurse continence advisors, you're going to see these patients too down the line. Because again, it's back to that recognition point of view, back to the fact that these patients who have babies, unfortunately, have difficulties emptying their bladder. And you'll see them. I mean, what can happen with bladder? You can get stress incontinence, we're going to talk about it. You can get urge incontinence, we're not going to talk about it. Fistulation. But postpartum urinary retention is important. Why is it important to you guys? Well, it's important for 2 reasons. One, they may well turn up on your doorstep with or without prolapse, but most likely with recurrent urinary tract infections, because they're incompletely emptying the bladder. You may see them because they have incontinence. Either that will be urgency because the bladder's half full, or overflow because the bladder's too full. And you'll see these patients, and you'll think, where the heck did that come from? And why did this 45-year-old lady get these symptoms from? Well, she's had those symptoms since she's had the baby. The only difference is that over time, that bladder retention has got a little bit more till it hits that point where it then becomes symptomatic. So, important. It's important because if you think about it, it's the innervation of the bladder. And you all know the innervation of the bladder. It's autonomic, sympathetic, parasympathetic. I mean, the sympathetic side, which comes from T12, L1, L2, basically stimulates the sphincter. As you can see, the alpha-adrenergic receptors to the internal sphincter to close it off, and it suppresses contraction of the bladder. Hence the reason we use anticholinergic medications for overactive bladder, because that's the parasympathetic, and that's the thing that seeks to contract the bladder and relax the anal sphincter. Sorry, not the urinary sphincter, beg your pardon. And then, of course, we have the epidendral nerve, which supplies the levator floor, which you squeeze like crazy if you have to go to the bathroom or you want to stop yourself leaking when you cough. And this is just a nice way of looking at the reflex, as it were, just to sort of give you some more of a visual idea. So what happens with voiding syndrome, in some way we've interfered with this reflex. And it can happen for all different reasons. And what the end point is this. just what you need to see if as your cough is starting to make its effect on you. But that is normal bladder function, and that's what we're trying to achieve. Well, why do they get in pregnancy? It's a number of different reasons why they get this in pregnancy, why patients get this in pregnancy. And really, there's overt and covert void and dysfunction. And the ones which are really the biggest problem long-term are the covert, like the sort of secret agents of bladder dysfunction. Because the overt, because they just can't pee, and it's painful, and they have 1,500 mils of urine in the bladder, and they may not pee ever. But that's overt, you know about that. The covert ones are the ones that we never really test for that well. We've introduced stuff here in Calgary recently. Again, the covert ones are where they have a residual urine. And if you look at the guidelines, like the NICE guidelines, the Royal College, ACOG guidelines, they talk about 150 mils. Normally when we're doing post-void residual, we talk about 100 mils in our patients for the most part, some less, some more, but 100 is usually the cutoff. In these patients, ladies postpartum, you got to give them a bit of leeway. I mean, that bladder's been squashed for God knows how long during labour and delivery, and so you've got to cut it a kind of a break. But you still need to watch it. What happens during pregnancy of the bladder? Well, there's a weight of this pregnancy on the bladder. I mean, all you ladies who are here have been pregnant, you know what the weight of the bladder, where the pressure this on the bladder is. Interestingly, the bladder actually has an increased bladder capacity because of the hormonal effects on the bladder. So it's counterintuitive because, say, if it relaxed, I wouldn't go as often in pregnancy. Well, that's negated by the fact that you've got this weight of a pregnant uterus on top of the bladder. However, when they deliver, the uterus suddenly becomes a third or a quarter of the size like this. The bladder hypotonia persists. So what happens, therefore, is that relaxed bladder can stay relaxed for weeks afterwards, but you don't have the big lump that's pushing on top of the bladder to make you go to the bathroom more frequently. So in a way, therefore, that causes increase. So it's counteracting each other. And so, here we go. This is always this bladder's first squeeze toy. I mean, it's the usual cartoons that go along with it. I'm not going to talk about stress incontinence in pregnancy, but still, I'm going to talk about void and dysfunction. It's important because you're going to see these patients with recurrent urinary tract infections, urgency incontinence, overflow incontinence. I'm just going to, as I just gave you a clinical example obstetrically of the last situation, I'm going to give you another clinic. This is actually a patient of ours, and this is classically what happens. 22, has a baby, has an epidural, this lady didn't even have instrumentation, she didn't have forceps. However, if you look at this, and you look at the risk factors again for postpartum void dysfunction, what's top of the list? Instrumental vaginal delivery. So, you say, I'm standing up here and on the stumping here saying, we shouldn't be using forceps. Well, I'm not completely saying that, but there is evidence, if you reflect on this, that a lot of these issues I'm talking about from postpartum injury are associated with the use of forceps. She didn't have forceps, and it was it's the perfect storm. She's in labour and delivery, it's busy, so before she goes back, she didn't really pee to the postpartum. She gets onto postpartum, people are running around, families coming in, babies yelling, and they forget that actually hadn't voided for, well, it says greater than 8 hours there. I think it was probably up to 12 or 14 hours. And then she gets catheterized because she can't. The classic one that happens with a covert one is the patient voids, but doesn't void very much, and usually voids overflow. So they'll say, I'll delay a little bit, but I've really got to rush there. And the obvious answer to that is, well, you've had a baby, it's all been pressure, and it's all swelling and everything else, and that's quite normal. That's the covert one, like the secret agent, because they have that urinary retention and they don't recognize it. Back to covert and overt. Overt is 0.3 to 4.7%. Covert's up to 40% of patients. Now, I will say to that, the corollary to that, the caveat is that 90+% of those will resolve themselves within the 2 or 3 days. Well, no one stays 2 or 3 days in hospital now after having a baby, but will resolve itself within 2 or 3 days. And back to my risk factors again. And this risk factors here, if you take this risk factor and put it into the first part of this presentation, it's exactly the same. Right? The relative risk is the same. Instrumental delivery, significant tear, prolonged second stage of labour, epidural analgesia. So it's a perfect storm. I've spoken about this. It's physiological, it's neurological, it's mechanical. And if you look at it, you can think about why patients would get retention postpartum. There's swelling in the genital tract, and so that is a mechanical kind of obstruction. Physiologically, the patients have retention because they've had an epidural oftentimes, they've had lingering effects, the same interferes with the reflex arc from a point of view of voiding. And the other thing is they're distracted. Plus they have neurological injury. And what happens is patients oftentimes get dyssynergia. And you've heard of dyssynergia, urinary dyssynergia, right, where the sphincter basically closes normally what happens is the sphincter relaxes and the bladder contracts. Well, the sphincter contracts and the bladder contracts, and then the bladder relaxes and it stays contracting. So it just doesn't pee. It's just not coordinated at all. And we do see that in postpartum patients, and that may well account for some of this we see. Epidural, I spoke about that. Motor blockade interferes with the feedback. And this is where the epidural goes, into that sheath again. And again, I say this wasn't quite the presentation, so this is talked about the bladder innervation once again. So how do we manage this? Well, we manage this with diligent postpartum assessment of the bladder, plus or minus catheterization. What do I do? Forget me, only interested in management in labour. I will catheterize patients if they've got, well, will offer to, I don't mean I will, if they've got really perineal edema after delivery, significant vaginal wall tear, if they've had a significant instrumental delivery with forceps, and I use that forceps and I get a skip in my heart. The guidelines. The guidelines are, and this is something to take home if you're involved in labour and delivery at all, is that the assessment of the bladder has to occur in 6 hours or less. Have to look. Simple as that. NICE guidelines, WHO guidelines, it doesn't matter who you guidelines. The important thing, once again, is recognition. That's the key. Again, this is more for postpartum, but if you don't recognize it, what happens? Is this a really big thing, or am I making a mountain of a molehill? No. You can get long-term catheterization, it's sequelae. I've seen a bladder rupture with this, and that's messy. Recurrent urinary tract infections that you will see because they've got an inadequate emptying in the bladder. If they get significant, as you'll see in your older patients, and these patients that sometimes can't void, they'll get basically a backup and get renal dysfunction, and obviously actually as far as renal failure. And of course overflow incontinence, which you'll see really presenting as an urgency and urgent incontinence. I've addressed how long it'll last. Generally it resolves itself within the time frame the patient would be in hospital shortly thereafter. I say I'm going to bypass the pathophysiology. I'm sure you're not interested in that. However, I'm going back to the case again. This lady's been unable to void now for 2 years. She hasn't actually voided a drop since she's had a baby. She's been very diligent at self-catheterization, and therefore, what are we left to do with this patient? Because we are at an impasse. If they haven't voided in 2 years, they're not going to void. They've got such bladder injury, and if I go back to the picture, basically where you can see the L where everything's just stretched out, basically. I mean, again, I didn't want to go into the So what can we do about it? With these patients like this, what can I do about it? Well, we can use self-catheterization. We can use medication, so we can actually use things to block the sympathetic or do something to promote the parasympathetics, but they don't really work. I mean, if we're going to do that, it's like the stuff they use for prostatic hypertrophy. It's gone right on my head. Flomax, sorry. Or they could use something called Bethanical, and the Bethanical is sort of something that went out with the art. And you can hardly get Bethanical, and you do it because you're desperate, right? Because these patients just aren't voiding. I've never seen anybody actually void with Bethanical, to be honest with you. I think it just treats my mind. So prokinetics were ineffective, and she's got a sacral nerve stimulator now. And it's a base sacral nerve stimulator just for the sake of, and Dr. Robert, who was here yesterday, she may have talked about this yesterday, does it here, and she put one in, and this lady now actually voids. So when I say she hasn't voided for 2 years, she hadn't voided for 2 years. I'll rephrase that. The alternative to that is posterior tibial nerve stimulation. We use that people use that for urge incontinence. Similar principle, it's a sort of Melzack and Wall neurological theory, where it sort of kids the bladder to work by stimulating some peripheral nerve that comes in at the same point where the exit point of the arc for the prokinetic to the bladder. So, everybody loves a cartoon. This is what I do, and I'll belabor the point is that really 6 hours is important, greater than 150 mils residual is important. I sort of subdivide this for indwelling catheters. I mean, this is my own, and this is from the literature. This is not just me picking figures out. This is from the literature, and there's been quite a lot of literature in the last couple of years regarding this. So that's void and dysfunction. You're going to see it: urinary tract infections, overflow incontinence, urge incontinence. The last thing I was going to talk about, we haven't got slides on, so you have to bear with me because I'm going to talk about it anyway, is about the birth injury and something called levator avulsion. Levator avulsions are something that has really hit the ground running because of the fact that now with high-end MRI, high-end perineal ultrasound, we're able to visualize not just cysts and bladders and uteruses and whatever. We can actually visualize the muscle of the pelvic floor. Levator avulsion's got a big name, and I had this beautiful slide about the missing link and everything, so I apologize for that. But it may be the missing link. We've always wondered why the patients have prolapse, and it's always very easy to say, well, you know, there's all this pushing down on the vagina from the head and everything else, but we just assume that, right? I mean, we have no real evidence to do that. What levator avulsion may show is that may well be the cause for prolapse postpartum. Now, practically speaking, how can you find the levator avulsion? And actually, you can find it on examination. And the puborectalis is the first muscle. If you go into the vagina and you got the urethra, and you go up to the side, you'll feel like an arc of muscle come down. This is levator avulsion at its least. And if you put your finger up there and there's nothing, so it just disappears up the side of the urethra, then they've torn puborectalis. And oftentimes that is associated with incontinence. The levators originate from the iliopectineal line, which goes from the back of the pubic bone down to the ischial spine. So it's like a curtain rod, if you will, between the two. And from that, the levators originate. When you examine somebody, and you say, well, I examined for the prolapse, and I examined for the uterus and everything, and then you examine to see what the muscle strength is. If you put your fingers into the vagina and go laterally, you'll feel the arc of the anterior pubic ramus, right? And then what you feel is usually this convexity of muscle. And what that is the obturator internus muscle, over which is lying the pectineal line, from which is arising the levators. And so it's bulky. If you put your finger, you can feel the bulk of this. If you have a levator avulsion, the worst variety, you put your fingers in there and there is a cavern as you go in there, and that's the worst type. And what happens with that is two things. One, is they have prolapse. And people have tried to associate it with paravaginal defects, and okay, I understand that, but it's it probably is the link with prolapse that we're missing from a point of view of being able to explain it. And the reason why I think it is a link is this, is that with studies that have been shown 2, 3, and 4 years out of patients who are proven to have levator avulsions, 60–70% of those patients, the avulsion seems to in some way rectified itself. We know that patients who have prolapse after they've had delivery, many of them, it rectifies itself, either with physiotherapy, with general activity, or whatever else. So it makes a lot of sense that we're seeing these levator avulsions. We can link that to prolapse. We can see the levator avulsions improve, just like we see oftentimes prolapse and incontinence improve as we get further away from the incident time of delivery. So look for it. It's important. If someone's told you they've had, you got it, forceps, then go looking for it, because oftentimes you'll find it. The problem is where the missing link and where we're missing the link, surgically speaking, is people have tried to reattach the levators back to this pectineal line through an incision through the vulva. It hasn't worked out very well. And you know, we're getting very theoretic about it, but we're still left with our standard approaches to surgery, and we may have to revise how we approach surgery in these patients and maybe all our management of the patients in the future. So with that, I think I've extended I've done my welcome, I think. So I always show this slide because it always puts things into perspective at the end. I sort of work overseas and stuff, and about 15 years ago I worked in Papua New Guinea, which is the most beautiful island you could ever imagine. It's the most feudal state. But every morning you'd go into this hospital and you'd go past Ward 10. And at Ward 10 every morning was full from violent crime. So it always puts things into perspective when I stand up here and talk about what I do and what we see when, you know, people living in that kind of circumstance. We had an TB ward, an HIV ward, a leprosy ward, and a dead on arrival ward, and they were the biggest 4 wards or units in the hospital. So with that, I'm happy to take any questions you might have, and hopefully it's stimulated some thought by talking. Yes?
I wanted to ask about the fecal incontinence regarding the anal sphincter repairs.
Right.
How does the person find, because I'm thinking maybe the neuromuscular or the sacral nerve stimulation as an option?
It is.
How do you find somebody that is doing that?
Depends which province you're in. It's interesting. It's A, having someone with a skill set that does it, and B, whether the province, in matter of fact, funds it. I mean, there was a time where Magley was doing patients from Western Canada. I mean, Saskatchewan, Alberta, and British Columbia.
Well, I have one lady that would probably travel out of
Yeah. I mean, it does work very well. It works very well for fecal urgency, especially. I mean, that's where it is, and that's what the young women have. I mean, that's the thing that oftentimes patients will complain more of, right? Because they just don't know when it's going to strike, and so when it doesn't know when it's going to strike, they don't know where they're going to be, and it may not be accessible to the bathroom. Generally speaking, they go through either urology, because urology have used it for overactive bladder symptoms, which we've used it for. I mean, the sacral nerve stimulator, and certainly in the Antipodes, that and Botox sort of go head to head when it comes to overactive bladder. And to your point, the same thing goes from a fecal incontinence, that the sacral nerve stimulator is used for that purpose too, as it is for pelvic pain. Which province are you in?
Oh, British Columbia.
Yeah. I could find out who's doing it in British Columbia. There has to be somebody doing sacral nerve stimulating. I mean, there has to be somebody.
We get a lot of referrals for BC.
Yeah.
Like I said, she would go to Alberta. I mean, she's gone to England.
Yeah. Well, we can take our clinic, and we can certainly look. So, as I'm not giving work to Magley, because I am not the person that's doing it, so she'll kill me. Yeah, we can. I'm sure. If you send the information, that's it to be looked at. I don't know what the interprovincial barriers are now or not, or whether Magley's still taking referrals from BC or not, which she is apparently.
I guess I just find it hard to figure out how to find these treatments.
Right.
We talk about it, but then when we try to find it, it's kind of
Yeah, it's great we can talk about it because we have it. So I mean, we actually have it where we are, and so we kind of it's kind of full service where this is concerned. You know, the physio is right the way, you guys straight away to us operating wise. But no, I mean, Magley's a person. I mean, the sacral nerve stimulators are like pacemakers. I mean, they're not cheap, and that's where the problem is. And you know, for sacral nerve stimulators, there's a testing done as well first to see whether they're applicable for it. Because you're not going to go the whole hog and have one of these things inserted and find out it's not going to work for you. There is a testing phase as well that Magley does. Yeah.
So I see a lot of seniors in the community with female hormones, incontinence and things like that.
Right.
So we look at things like diet, we look
Yeah.
at medication, tone and things like that. Is there anything else that
I mean, those patients who are elderly, I mean, really, they're down the line, and you know, they are the patients that had the 5 children, they had the tear with the first one, they've put up with anal incontinence for a long period of time, and you have to deal with them from a dietary point of view, some kind of exercise, if you get them an exercise program. They don't do well with medication, and often the medications used for that really, especially the ones you would use, you may interfere with other medications they're taking anyway. So, yeah, you're looking at dietary management, constipatory agents, which of course throws up a whole different scenario, constipating the elderly, and that's your best management for those patients, unfortunately. Yeah, there's nothing much more beyond that. I mean, there was a time when we used to bulk the anal sphincter. You know, like we do bulking of the urethral sphincter, we used to do the anal sphincter too. It kind of fell by the wayside, really, because just like with bulking of the urethral sphincter, it doesn't last that long. And the problem with it is you've got to put a hell of a lot. It's not like you put it into a urinary sphincter where, you know, the urethra is as big as my little finger. I mean, you put it into something that's this big, and so you have to put a heck of a bulk in there to get any benefit. You know, and there's problems with the actual stuff you use, the bulking stuff, the fact it migrated. I mean, it's a real problem.
Thank you so much, Dr. Birch, for being here. Sorry about
And
all
I
the
apologise about the
hassles.
original
Yeah.
presentation. Yeah, it's a lesson learned. I won't try and adjust my talk the night before.